So when you're preparing your QI report is due back to DHS on November 24th this year. The goal of this whole process is to prevent the progression from opioid use for acute pain to chronic pain, to reduce the variation in opioid prescribing behavior among peers, and then clarify best practices for opioid prescribing to ensure patient safety while providing appropriate pain management. And you are tasked with doing QI on 2020 data in the year 2021. And next year, you'll get 2021's data, and you'll be tasked in that year to complete the QI report in 2022. Hopefully that's not too confusing. So this form, the QI report form, is designed to help you document what you did. In order to select a potential solution or activity aimed at improvement, you have to first understand the problem that you're trying to solve and understand what is perpetuating that problem and whether the solution you choose will actually solve the problem. So, identifying your opportunity for improvement means describing how you used data available to you to understand your prescribing practices. What did you look at? How did you know whether you were an outlier in your practice, or how did you know this? And then what research or resources did you find helpful when you're developing your plan? Like, why did you choose what you chose? What did you identify as your improvement opportunity? And were there barriers you needed to address to work on improvement? Measuring improvement does not have to be hard. We talk about looking at data. Please don't freeze up over that. Keep the QI measures focused, simple, and timely. Quality improvement is short, iterative steps that change something. Test it, try it. If it didn't work, change it, try it again. If it works, make it stick. So consider using one process measure maybe and one outcome measure for each improvement technique that you select. If you are going to use a registry, you might have your process measure as how often do you update it? Is it updated? How often is it accessed? Did you use it? An outcome measure would always be, did you improve prescribing? Did you improve the outcome of the patients then? And then tracking data at the beginning, middle, and end of your improvement cycle is usually kind of the minimum. You don't have to make these long cycles. We always say, if you want to try a new form or a new process, one patient, one physician, one day, try it. If it works, do it again, or make it better and try it again. It doesn't have to be a long, drawn out thing, but we want you to test it enough to know if it works. You don't want to just keep doing something to do it. And if it's actually not changing the outcome, you don't want to keep doing it. See if the changes makes a difference by noting them on a graph. So if you're tracking something over time and putting a dot every time and drawing a little line, that's called a run chart. If you change something today or this hour, you might want to note that on the graph, because if suddenly it improves, you go back and say, that was the one that made the difference. And then you can do this on a piece of paper too. You do not have to be fancy, because this isn't a forever project. Then measure potential unintended consequences as well. For instance, when we were doing postoperative prescribing with our groups, we asked them to specifically note if a patient called back with pain-related problems before their first post-op visit, or if they requested a refill before then, or if they went to an emergency room or an urgent care before that, because that would imply that they didn't have their pain needs met. And people were tracking them. Some people made phone calls. Some people specifically followed up on every patient, and some people just tracked incoming. And we did not have unintended consequences to the process changes that we made, so that we felt confident about the changes that we had instituted. So the second part of this is to plan and make the change. So at this point, you're probably still at the planning stage, and we highly recommend that planning take more time than you think it should. Describe in the report what you did to improve your prescribing behavior. Be specific. I don't just say, I learned more about this. Well, okay, but did you do something about that that was going to change the outcome? And then when did you begin and end your tests of change? And we are asking that you do that within the 2021 year to improve your 2020 prescribing. So if you've got something already in the works that you've been working on, maybe go back and check and make sure that it's working, or modify it and summarize that work in your QI report for November. Who was involved in the change process? Did you pull in your team members? Did you include patients? Did you pull in your peers? And did your tests of change go like you thought they would? So if not, what happened? I mean, it's not at all uncommon for you to say, oh, I didn't even think about that. And then have the team say, oh no, we just broke something that was working. So what did you learn from the process? The other part of learning from the process is, how well does your team do a quality improvement project together? And how well does your organization support you when you do that? And are you reaching up and reaching out to make sure that they know you're doing it? And then describe any unforeseen barriers that you needed to address. When you reach out to your quality improvement coordinator or liaison, it's highly probable that your organization has been doing a bunch of these things already. And so maybe your team just hasn't implemented something that they've tested a long time ago. Use their work, make it happen, and report on that. So the third part is studying the outcomes. Again, doesn't have to be scary. Do you have quantitative measures of your progress towards the stated goals? Did you count anything? Did you measure something that's countable? And then how have they changed? Do you have qualitative assessments for your progress above for the stated goals? So asking your team, your peers, your patients, how did that go? Did that work for you? Did this mess something up? What could we do better? So what are they saying? And then what have you learned from the qualitative assessment overall? Are there unintended things that you discovered? And then were there unintended strategies, consequences to the strategies that you implemented? And then what challenges remain? So the last part of this is sustaining improvements. What tools, resources, technology will assist you in sustaining the change? Before you hardwire something, make sure that it's actually worth hardwiring, that it's the right thing for the patient and you, and that it follows accepted protocol. So some of those things might be a new or updated policy or procedure, forms, workflow changes, something you do different in your EMR, monitoring systems like registries that need to be kept current. That's a sustaining process. And then changes to job descriptions or responsibilities for staff. If you've decided that your team needs to work in a different way, then maybe you need to update their job descriptions. So these are ways that you can sustain that improvement. And then the form will ask you for additional information. So they're going to ask you if you've got anything else you want to share, like challenges that that came about. We've uncovered so many systems problems, and systems problems are ubiquitous. You've got them. You've all got them. So it's okay for you to communicate what those systems challenges were. You're probably not alone, but I think that when we get reports in, we can summarize and we can share and identify, just like any other research project, to say at the end of the article, and here's the other things that need to be solved. So who wants to pick up this gauntlet and work on it? And what were your concerns about this work? What didn't quite feel right? Or what are you thinking you need to keep changing? If you've got questions, if you had some wonderful success that you want to share, or an aha moment and key learnings from that. We never want you to send in any personal health information. So don't send us a spreadsheet with patient names or medical record numbers or provider IDs or any of those things, because we can't accept it and you can't share it. So summarize, please. And then there's other summary information, like you need to report your continuing education, like the course or title, sponsor, location, date completed, and then provide a link if it's online. Describe how you use the PDMP to incorporate into your practice. Then provide the name, title, and signature of an individual in leadership who has supported your QI objective, and then attest to completion. We have so many resources available to you. If you don't have a QI liaison, even at this late stage of the game, please contact DHS and we will do our best to connect you. These webinars were designed for both the QI liaisons to help support their work, and also for those of you that don't have a QI liaison. And we feel that the guide and the toolkit and everything that we have available to you, you should be able to complete any of the forms that are required of you by just using those, but reach out if you need help. And then our ICSI website is here. And if you want to connect with DHS staff, just use this link. And if it's a question for me, they'll forward it on to me. And again, their website has another wealth of resources on this project. So, okay, do you have some questions now?
I do. Well, it's not questions, but more comments, but I will share these comments that are made. So one participant commented that patients understand these imperatives and are starting to look at other treatment modalities like medical marijuana, stem cell injections, using a lot of over-the-counter products. These are not necessarily safe alternatives for that patient, and the prescriber commented it's hard to balance the messaging. So this was just a comment. And then another comment that was made was, this feels like a lot of work, that this person says that they already do a lot of these things. And if they had not taken over for two retiring physicians, they wouldn't have been put in the program, and that's really frustrating.
And we completely understand. Mm-hmm. And I think if you would just keep your QI process focused, find one thing that you can improve in this, what seems like an incredibly overwhelming population of patients that you've inherited. Pick one thing that you can improve. We know everybody can improve something, and please don't consider this like a year-long research process. Just keep it simple. And the quality improvement requirements that DHS is asking for in this year, because we are still in COVID, is a low bar. And I don't want you to fret about it. I want you just to pick something, focus on it, and do it now, and then submit your form and be done. Sarah, do you have anything to add for these two comments?
I think I would echo your comment that we are really interested in having this be, this first year, our expectations are modest. We know that the data that we will run in the spring of next year, there's a short amount of time left in 2021. So we don't expect, a significant data change. We just are hoping that this is an opportunity for people to test a small change, just like Audrey said.
Here's some things that we learned. There are going to be patients who will require chronic opioids. And there are a whole host of patients out there who have been on opioids for a very long time. They were started a long time ago. And our goal is to reduce that number of people who end up on long-term chronic opioids by not starting them on chronic opioids. And there are pain providers who have done a very good job of really understanding that one of the best ways to test a patient who has chronic pain, who has not used opioids yet, first they go through all the assessment to completely understand the source of that pain, to really know what's going on, and to treat anything that can be treated to reduce or alleviate the pain. And then they're trying every modality that they can try that is available and accessible to the patient. And we understand that sometimes that's a barrier. We all know that. I wish there was an easier answer for pain. There are times when they will try a trial on chronic opioids, but they have very specific criteria. They have very specific parameters. They are monitoring it carefully. They know exactly what to look for in terms of, did that actually cause relief? And what else did it cause? And they're positioning it with the patient in such a way to say, this is a trial. We're starting it here. We're going to end it here. And then we're going to figure it out. But never just starting and then continuing without all of that ahead of time. So I recognize that some providers have said, I'm not starting any more patients on opioids. Some providers have actually said they're not prescribing opioids anymore. And we don't believe that that's best practice, because opioids are a tool, a very important tool for pain management. If you don't want to prescribe opioids, then perhaps having a practice where you're not seeing patients that require opioids would be the best practice change. So we know that everybody doesn't want to do this, and not everybody should be prescribing opioids at all if they really don't want to do this. And we're not trying to make you fit into a round peg into a square hole. If this isn't your practice that you want to do, then we applaud you for recognizing that. So I just want to make sure that people know we're not trying to say stop all opioids or cut it all out. And like Sarah said, your data won't change overnight, and we are okay with that. Slow as it goes. Thank you so much for participating today. We appreciate all of you and your comments, and these will be posted on the ICSI website. Have a great day.